Welcome to This Explainer. Today, we're unpacking a huge disconnect: what healthcare providers want versus what communities actually need. Think about it. Are we actually listening to patients when designing childhood screening programs? The data says nope. Here's the deal. Health policies in low-income areas almost always fail if we don't consult marginalized communities first. Researchers actually talk to people, from deaf adults to clinic managers, using focus groups to gather their real lived experiences. And they found four major battlegrounds in program design: the approach, the method, the location, and the personnel. Let's look at the first clash. Users desperately want universal screening, but overwhelmed providers prefer a targeted approach. Why universal? Because for families in dense urban areas, finding transport to specialized clinics is an absolute nightmare. But providers face a really harsh reality. They literally just don't have the staff to screen every single kid. Clash number two is the method. Providers love quick, indirect parental questionnaires because it saves them precious time. However, parents strongly disagree. They argue paper just isn't enough and demand direct physical testing by actual professionals. Families face huge barriers here. Illiteracy makes English forms totally unreliable. Plus, there's massive stigma around disclosing disabilities. This sparks our third clash: location. Where should this happen to guarantee quick, low-cost engagement for busy parents? Caregivers say familiar local preschools are absolutely the best communication hub to reach these busy, working parents. Finally, who does the testing? Users want highly trained specialists, but providers know those experts are incredibly scarce. So, what's the fix? Task shifting. This empowers clinic managers to train local non-specialists for basic testing. To help policymakers out, researchers actually identified 3 actionable strategies to bridge this gap and create a compromise. First up, combine the methods. Use translated questionnaires to flag at-risk kids, then follow up with physical screening. Second, change the location. Culturally adapting the program to happen at familiar preschools builds massive community trust. Third, embrace task shifting. Training local preschool teachers to help safely eases the crushing burden on specialized doctors. Together, these steps form a logical sequence for rolling out a truly inclusive, community-based screening program. Ultimately, actively integrating the real lived experiences of local residents is the only way to design effective policy. I'll leave you with this. Will future healthcare programs be built for the community or with the community?